Well, thank you very much for the invitation. It's a great pleasure to be here. I also would like to thank all the patients for the report, because at the very end, we are here because of you. Many of us are clinicians. We start the profession, try to help patients, but there is a great frustration that many times we try to help and we fail on that. So it's much more a struggle that I got into neuroscience as a dentist to try to find things beyond that I was traditionally trained, to try to find solutions for patients, or at least the beginning of a different concepts. I was asked to talk about how neuroimaging can be used for that, so brain can be the target for not only research, but also treatment for patients and even education, and how things that are in the horizon, for example, artificial intelligence, biomarkers for the brain, and integrate also, we're talking about genetics, how that affects the brain in many ways, and the opioid system. So we are talking a lot how problems we have in our society, but before you actually even prescribe opiates for our patients, how our own endogenous opioid system is affected by pain and how we respond, including placebo. So as a disclosure, all the many of the technology described here were developed completely at the University of Michigan. So some of them were licensed and for startups spin-off inside the University of Michigan. I'm a full-time researcher. I have a lab that now it's around 20 people with a very multidisciplinary team. Today, many of you talk about the idea that only to help our patients is to have a multidisciplinary team. But that concept is going beyond the health system. So if you're a dentist, physician, physical therapist, so now the idea is that multidisciplinarity is like with bioengineers, not only also neurologists and physicians and dentists, but also neuroimagers, bioengineers, visual technologists to work with augmented reality, mathematicians, biostatisticians for artificial intelligence. So it's a combination of that can have the out-of-box ideas that can help patients. So today we're going to talk about how that in a lab that is very neuroimaging based, we develop some of mobile technology to try to have more precision to collect, because we're talking about pain and pain intensity, but actually the way that our brains measure pain or perceive pain is not only the intensity, but also the area of pain. So, and that is not only for the entire body or by regions, but even the region itself for the head or for the arm, it's very precise the way that develops. Also, not only MRI, but special positive emission tomography that we can look at the molecular level the brain of our patients during the attack. We were talking about migraine. So how during the attack, the molecular, the opioid system is affected by the attack, and also allodynia, for example. How can we target these areas in the brain or this mechanism doing, for example, brain stimulation? Is there a particular target in the brain that have some results and relief for the patients? So, and also, how can we bring all this technology in neuroimaging or concept to the clinical environment? Because we have a positive emission tomography, MRIs, these are large, important tools that we have, but it's sometimes very difficult to bring that to the clinical environment. And also, as soon as we have that technology, that information, how can you bring to that information for diagnosis of monitoring to the clinician or research right there in the clinical space? So just to give you an idea how pain is something that it's very difficult to measure. So these are patients that, TMD patients that went through a clinical trial in brain stimulation in our lab. So you can see that the one in your left, you have more pain in the left side. So one in the middle, we have like a balanced pain in the right and left side. And the one in your right, you have much, take much over the entire left side, but also pain the right side. Which one gave you like a VAS that was highest? So you think that would be the one in your right, but in fact it was the one in the left. Because it's pretty hard to give a subjective number that can represent your pain. So when you start to think about other ways to measure pain, so if you average all the cells that are affected, I mean areas in your head, so from 0 to 3, and you get an average of all the cells here. So 0 is no pain, 1 is mild, 2 is moderate, and 3 is severe. You start to have a better idea who is suffering the most. And the area is the same. You can have idea of like 36% of the area of the head is affected. And if you combine both, you have a better idea about who is suffering more than the others. So, but still, it's a very subjective way, but we are trying to be more precise in that, more accurate the way that you translate that. And we are not only for the entire body, we are collecting data and analyzing data for the entire body, but also you're looking at regions. Why that? Because you're getting patients that are more complex now. So you can get a patient that has migraine, but also had migraine and also fibromyalgia. If you're testing, you're doing a clinical trial with a drug that is for migraine, you want to know if that drug is actually having more effect about your headache than your full body, or maybe that is actually being more benefit in the entire body. So we are quantified by region, even in intraoral region too. So why does that make sense in a way that how that it translates to the brain? So just to give you an example how pain area intensity together have a better idea, is the way that your brain, especially the opioid system, is affected by pain area intensity together. So we use a positron emission tomography to scan patients with migraine. So these are patients with episodic migraine, less than 15 attacks per month, and chronic migraine, more than 15 attacks per month. We inject a radiotracer that goes specific to the mu opioid system. So mu opioid receptors are where your opiates that you prescribe actually bind to have the effect. So what happens is that during the attack, if you compare migraine patients with chronic, with episodic, the area that is most affected is the amygdala, which is the limbic system that is the reaction of your body, emotional reaction to a stimulus, because you also, not during the attack, we also applying thermal stimulus. If you look at this opioid, endogenous opioids release, which is beta-endorphins, like the ligands for the mu opioid, so the more pain they have, the more of release of endogenous opioids. If you look at the amygdala, 71% of that activation during the attack was if you are episodic or chronic migraine. So chronification of the pain really affect the amygdala activation for the mu opioid system. The other thing too, we talk about allodynia, and allodynia responded to 8% of that difference, the variance in activation of the amygdala. And the pains, which is the area intensity together for the head area, respond to 12%. So 71% of the amygdala reaction to the migraine attack. So this is the average of all the patients with episodic and chronic. So we had the activation of the amygdala. So these are the way that you're now pushing to our students in the pain courses at the University of Michigan School of Dentistry. So they see the patients, they put the information in the app of those patients, and we collect the data and the aggregated data of the patients for the course. And then we teach based on their patients' aggregate data. So what you see that is around 40 clinical cases of patients with TMD. So we also divide in dental pain, pulpitis, for example, migraine, and the trigeminal neuralgia. So this is the temporomandibular disorder group. You can see that the area that is affecting 40 patients with that. But the interesting thing is that if we look at patients, the longer the pain is, the larger is the area from the epicenter, because we can look at the aggregated data, where is the epicenter of like 40 patients, 50 patients. And the longer your pain is, the area increases from the epicenter. If you are, and the interesting point is that I'm going to talk about later, is that how opioid system works, is that after 5 years, you start to see changes not only in the opioid system, but also in the area that increase from that region, epicenter. So these are now we are going to 1,500 patients in fibromyalgia, divided between male and females. So these are patients that are using that. But now specific to chronic temporomandibular disorder, and look at the opioid system of those patients. How do we do that? So this is funded by NIDCR. We have been using, what we do is that we get TMD patients and we get health subjects, but you want to compare them. So what do? We put a needle in the masseter for myofascial pain, where it's the most common. We put the needle there and we inject hypertonic saline, which induces pain that's prolonged. So it's a computer system that if the pain goes down, the computer system injects more hypertonic saline. So meaning we bring the pain to the same level for the health subjects and TMD patients. So we can have a better idea how sensitive both groups are and how the opioid system respond to that. So what do you do? So there's all the patients with the TMD plus the health controls. So this is the average of pain of all the patients. Again, so during the pain, comparing the patients with TMD, patients with health control, it is the limbic system that most affect or impacted with the TMD for the opioid system. So more release of and less of mu opioid receptors available during the TMD pain. And this in the parahippocampal area, which has the memory of the pain and really attached to the function of the amygdala, for example. So the interesting thing is that, of course, the TMD were much more sensitive, meaning they need less of a hypertonic saline to be injected in the masseter, more than so around a double than compared to the health controls. And the more chronic the patients were with the TMD, so more of opioid, less of the receptors, more opioid receptors available, either by decreasing the number of more opioid receptors or increase of the ligands for the more opioid receptors in the system in the parahippocampus. So we'll talk about genetics, but something's just we didn't believe at the very beginning because we need a large number of patients. But we are trying to see if there is any effect of genetics at the amount of data that we had. So we look at the count. We talked several times here, several colleagues, much more experts in the field. So we look at the count, which affect, for example, the release of dopamine, but at the end indirectly with the opioid. What we saw is that the Conti 158, so the VV, VM, and MM, so they have completely different ways in sensitivity. So when you look at the sensitivity, meaning how much of a hypertonic saline they need to feel pain, so the group with health controls, they were VM, MM, which were more sensitive than the VV, Val. And the TMD, VV, a little bit less. But when you look at the TMD, VM, MM, so they were much more sensitive than the health controls. So the polymorphism for Conti in the temporomandibular disorder patients is very impactful, especially in the sensitivity of the patients. Now look how the parahippocampus binding, or actually number of receptors available, decrease in the same manner related to the sensitivity of the patients and the polymorphism. So we can see that we have also significant marker here. If you are TMD, VM, MM, so the polymorphisms of Conti, they are much more of a probably release of these ligands for the more opioid. So I think we talked this morning that there is a set that's part of the patient polymorphism or genetic profile, and part also that also is related to their sensitivity and chronification too. Interesting enough that patients with TMD, that the VM, MM, the Conti polymorphism, they were much more chronic pain than the VV TMD patients. And after 5 years is that you see the opioid changes in the brain of those patients in the parahippocampus. So can we try to target the brain to actually have any effect in this system? So first, we try to find a technology or a technique that you could target the brain. So we have to look at the gold standard. So neurosurgeons actually would implant still electrodes in the motor cortex and stimulate the area of the pain. So the face is represented right below here. So what we did is like define a protocol where you stimulate the motor cortex of the patients non-invasively. So what happened is that we did 5, with transcranial direct current stimulation, 5 daily sessions of those patients, and another group with VAS, 50% of decrease of pain in 1 month. But when you look at, these patients had pain both sides. We only stimulate 1 motor cortex. We change only pain in this area intensity in the contralateral side, not in the ipsilateral side. So we are very precise, not only to target the pain, but to actually manipulate the pain. So this is the areas, so areas in greens are areas that were decrease the pain, and we were able to do that control that in the first week of treatment. And actually what it does is that as soon as we stimulate the brain, you have a release of endogenous opioids of those patients. Very similar with the sham technique. I can talk more about that. Can you bring that to the clinical environment? So some colleagues are doing like the biomarkers, this slide from Dr. Shamaki. But the thing is, we are trying to do that by using optical imaging. So in the environment, the dental environment, so we put like infrared sensors that send, and with a change in blood flow oxygenation, we have idea where the pain is actually process is going. And we send that information directly to your view using augmented reality. So we apply dental code to patients with dental hypersensitivity in the dental chair. And what we had is that as soon as they felt the clinical pain, so they felt the clinical code, so they had one peak at the contralateral sensory cortex for the homuncular area for the face. And then when they felt pain, another trigger, another peak here. The prefrontal cortex was different. They were expecting the pain. There was a huge activation of prefrontal cortex when they are expecting the pain. When they had the pain, the dental pain, so the pain actually either flat or down in the prefrontal cortex. So we actually publish about this cascade of events that occur in the brain and use that for artificial intelligence to predict who is paying or not, and define how in the closed system, either to send as augmented reality, you can see in real time what's going on with the patient, and also to trigger the brain stimulation. So we define the clinical augmented reality and artificial intelligence, what you can see in real time and what's going on in the patient's brain activation, using also with augmented reality with the softwares that we develop. So with that, we can also define a software that in our study who was in pain or not, and which side of the pain was, using the optical imaging combined with augmented reality. So this study that we now under review. And demonstration of that. Yes. So first you're going to see one of our postdocs, and I'm using the augmented reality with the system directly connected with my HoloLens. So this is the way that I see. This is true activation in real time of the patient. So we still can see the patient. You can see it's almost like mixed reality. So I can see the activation going on right there in the clinic with the patient seated. The other thing that we do is now collect that data that we have, permutate it, and the system define who is in pain or not. This is the left side. So look at this right side. When it's red, you're going to see activation going on in the sensory cortex and also in the prefrontal cortex. This is from our patients. Here, so you see growing and the area that it is, and combining with the prefrontal cortex, we can have idea about what is using artificial intelligence to who is in pain or not, but have the information there. It's still at the very beginning, but it's still, we are combining technology, but you have that information right there where we need, which is the clinical environment. So for sure that neuroscience and technology can improve a way to detect, but also to localize pain in the clinical environment, and we can use that to be more reliable and more objective with the way to provide personalized treatment for those patients. It's at the very beginning, but something that we can really help our patients for the future. Thank you.